Good morning. Before I start and introduce myself and introduce the next speaker, I just wanted to say, first of all, what a tremendous event. These events have been going on now for several years, and the engine behind all of this, the person that makes this happen year after year, is somebody who earlier gave a lot of kudos and credit to a lot of folks in the room, but always leaves herself out. So I just want to recognize Patricia Maxwell, because without her vision, this would not happen. And also just a huge, huge thank you to Rotary in general, of course, but to the Rotary Club of Belmont and Redwood Shores. What an amazing Rotary Club and a great, amazing just group of human beings that give back to their community day in and day out. So thank you, Ray and the whole club, for making this happen as well. So my name is Siadatan. I'm the National Vice President of Sales and Strategic Alliances for Silverado, which is recognized as the global leader in providing care for those with memory-impairing diseases. And we have become the first and only entity in the United States to be accredited by Alzheimer's Disease International for our dementia training and certification program. We're one of only 5 entities around the world, and the other 4 are research institutions, so we are the only business globally that has been recognized by the Alzheimer's Disease International for the way that we provide care for our residents. By the way, I also want to say, for the Rotarians in the room, I'm also a longtime Rotarian. When I started the very first Rotary Club just down the road at Mills High School in 1987, I started the first Interact Club. And since then, I've been involved with Rotary from 1987 until this day. So to say that Rotary runs through my blood is an understatement. Today, it gives me great pleasure to introduce our next speaker, and a longtime friend of myself and to Silverado, Dr. Mehrdad Ayati. Dr. Ayati is well known nationally and internationally in the field of geriatric medicine. He is a physician, a speaker, an author, and an educator. Dr. Ayati has served as the medical advisor to the United States Senate Special Committee on Aging, providing medical advice on aging and challenges faced by the aging population in the U.S. He is an adjunct assistant professor of medicine at Stanford University School of Medicine, where he teaches geriatric and internal medicine. Dr. Ayati joined Stanford University School of Medicine in 2011 as faculty, where he taught and practiced internal medicine and geriatrics at Stanford Internal Medicine Clinic, the Stanford Senior Care Clinic, Stanford Concierge Medicine, and Stanford Executive Medicine. Dr. Ayati is a member of the Ethnogeriatric Committee of the American Geriatric Society and serves as a faculty advisor for the Center on Longevity at Stanford University. He is a member of the Healthcare Advisory Committee of Northern California and Nevada chapter of the Alzheimer's Association, and is the geriatric consultant on aging research projects at SRI, Stanford Research Institute. Dr. Ayati is also the editor-in-chief of the Journal of General Medicine, Open Access, and is the co-author of Paths to Healthy Aging. And I think he would tell you that one of the things he's most proud of is the fact that today is his son's 11th birthday. And yet he is here today with us. So Dr. Ayati, thank you so much for joining us today.
Okay, let me just put it here. Do I need this? Yeah. No, it's good, yeah. Okay. Okay, well, good morning, everyone. And thank you so much for inviting me. Again, I'm so pleased to be here. It's an honor to be here as well. And again, I see all the morning energy, and everybody's willing to learn about mental health issues. But again, I'm not a mental health expert, but the topic that I'm using, it's about something that we all dealing as or either a loved one or even a professional for people with dementia, that they are they are now labeled as mental health disorder as well, and as something that we never faced it in the past. And I want to share with you why the dementia is not only about memory loss, and is actually is a lot of other things going on with dementia that can cause that. Okay, I don't have any conflict of interest about a topic. Unfortunately, I'm not getting paid by any pharmaceutical or biomedical. That's why I still have to work till one day I'm going to be retired. And the first thing I want to talk is about understanding about dementia. Again, many of us think about dementia as only about short-term memory loss. That's true. That's the main symptoms of dementia. But dementia is not just the short-term memory loss. It's the general term for a group of the brain disorder, and that's exactly not in a specific disease. That's why dementia is kind of like it's like a name that has a lot of the neurological situations going to come under this umbrella. That's not only affecting memory, but also affecting thinking and social abilities. And that's exactly enough to interfere with daily life of the people. That's why it is important to understand that dementia is not only about the short-term memory loss. No, when we talk about dementia, there's a lot of other symptoms it's associated with dementia. They can be depressed, they can have apathy, psychosis, which is delusion, hallucination, delirium, physical aggression, verbal aggressions, wandering, disinhibition, irritability, and anxiety. Many of you work in the senior care field. Have you ever seen any person with dementia with any of the symptoms? Yes, that's actually, I believe that when we talk about dementia, that's exactly majority of the problem. That's the reason of all demented people will be placed. They need memory care, they need assisted living facility. They can't be taken care of at home. And that's exactly the topic that the caring of people with dementia costs a lot. And again, globally, as the number of dementia we're going to talk about is increasing, this is exactly what we call behavioral disturbances related to dementia is the cause of, again, the cost related to the dementia situation. Now, first we wanted to say what is dementia, because that's important for everyone to understand what does it mean when we talk about dementia. And when we talk about dementia, we just need to understand the brain anatomy. It's important for all of us to know about it. The brain anatomy has two parts, which is technically we have gray section of the brain and we have a white section of the brain. Since birth, we started developing the gray section of our brain, which is technically most of the neuronal effects is actually going to be in this side. That expand till late 20s. Now, that somebody can be till 30, 31, but technically all of us, we develop the gray section of the brain till like 28, 29, and this is the time that their wisdom and experience is much better. There's a lot of the questions here about should we change the driving age from 16 to 28? And that has been discussed a lot. I mean, the neuroscience, that is it a good time to change the drinking age from 21 to 28, or 29? But it's just all about technically a brain is like a sponge. It's small, it's just getting developed, and it's actually that a sponge or balls getting expanded till like 29, 30. Some people are so lucky they expand till like 30, 31. But technically, there's no human, not all like that, apes like that, gorillas like that, chimpanzees like that. Nobody's developing brain after age of 30. Technically, the gray section is stopped, and what happened is actually the white section of the brain going to start, which is 60% of the brain, from 20s to middle age, start to pick at that age. From the middle age around like mid-50s, the white section of the brain also going to stop. And this is the time that technically the brain started to come to shrinking. But technically the shrinking of the brain is not in the midlife, it's starting at the age of 30. But the white and gray sections balance going to be changed in the middle of the life. Now, when we look at the brain, there's many areas of the brain is there. I just wanted to make sure I put my phone that by knowing about the time. There's a different type of the brain section there. The red section is the frontal lobe. And the yellow section, orange kind of like, is temporal lobe. These are very important lobes because the frontal lobe is thinking, memory, and all the behavioral movement is affected by this red section. And the yellow section is the hearing and the learning and feeling. When somebody gets any neurological disorder, especially what we talk about dementia, that red and yellow section is going to be more affected. The frontal lobe and temporal lobe, then we do MRI, we look at the frontal lobe, we look at the temporal lobe, and we see the degree of atrophy is significant. And think about it, not just look at it, the frontal lobe is technically the one that managing your behavior. Like for example, you invited me as a speaker, you expected me to come here and present my lecture and also behave appropriately. If I'm going to start to become weird and strange, Patricia Maxwell next time is going to say, Dr. Ayati was so strange this year when he was on the podium and started speaking. Then the first thing she's going to do is just say, probably we need to call a doctor to do MRI of his brain. Maybe he's losing his frontal lobe. But that's exactly what's happening. Now, the kids also don't have, the frontal lobe is the last lobe that is just getting developed through the technically early 20s to like 28. That's why a lot of the working plan or logic thinking may not going to happen if they're like age of 30. You will see the people at the age of 30, they think more wise and more experienced than we are in the 2021 because of the frontal lobe as well. And the other part of the brain also is important, but it's not about our topic, but they're technically doing the different things. Like, for example, parietal lobe is language. A lot of people that get dementia, they actually are starting to losing their speaking abilities because that part of the brain is also getting affected as well. The other things which is so fascinating is the hippocampal area. It's a little bit about anatomy, but it's good to know about it. Is the hippocampal area is the center that just lying inside the temporal lobe is responsible for learning and short-term memory. Like, for example, if the people on the audio section tell me, oh, Dr. Ayati, you have to press this in order to have the slide change. And in a couple of minutes, I said, what was that? Which one I should press? That means definitely I have a problem with the hippocampal area. If you're learning the gadget, for example, if there's a microwave or there's a new TV, I wanted to know how to use the remote and everything, that goes to hippocampal area. If somebody tell me I need to learn it. And anything I'm telling you right now, it actually goes to your hippocampal area, which is your immediate learning, short-term learning. If you like my speech then or lecture, then you're going to send it to your long-term memory. If you don't like it, you will delete it. And that's the way it works. But technically, the hippocampal area is the area of the brain when we wanted to diagnose someone with Alzheimer, we're looking at the MRI with memory protocol to see if that area start to get shrink and small. And that's a very, very fascinating part. Now, what happened to the brain? The brain volume start to decrease starting to shrinking. After 65, the speed is going to be much faster. The blood circulation is also going to be down 5 to 20%. That is a normal aging situation. And technically, as I said, the gray section of the brain after late 20s start to shrink, and the atrophy is going to happen more in the frontal lobe. Technically, frontal lobe is the first lobe that we all expanded, and is the first lobe that we started to losing it. And this is the atrophy really affects in different parts. Now, imagine if somebody has like high blood pressure, somebody is smoking, somebody is also drinking too much. The amount of the blood circulation to the brain will be more and more. Like 5 to 20% is normal drop in the blood circulation, will be 40%, 50%. This is what we call brain hypoperfusion. Means brain gets less blood. That's why the amount of the shrinking and atrophy will be more and more in the next decades. Again, don't think about that atrophy of the brain happen when we enroll in Medicare. No, it's not. It started at the age of 30, and every decade it started to go up and up. Now, why this is happening? Why we started to have atrophy? Technically, our body designed to die. And that's a very important and fascinating thing. From the beginning of life, every single second, or cells programmed to die. This is what we call apoptosis, which is technically is an automatic program for all our body and organs prepared for dying. In every single seconds, like for example, Think about the neurons. Is all the chemical things is happening in this picture you see, and the cells getting die. Now, the kids at age of 8 to 40 years old, they lose 20 to 30 billion nerves a day. Now, at age of 50 to 70, normal situation like today, we lose 50 to 70 billion nerves today, till end of the day. And somebody with dementia, that speed is much faster. It's like 250, 300 billion nerves a day. No, when you go to take a shower, you're actually losing billions of your skin cells, your hair cells, all the hair follicles every time when you take a shower every day. Every day with the bowel movement, we're actually losing billions of the cells through our GI tract, gastrointestinal tract, and this is happening every time when we urinate. Inside the urine is billions of the cells from all over the body, goes to the kidney, and it also is going out. This is a normal situation of our body. This is a programmed way that our body designed to die. And this is exactly happened with the brain starting to age of 30 to prepare itself for more shrinking and atrophy over time. And when it's happened, technically all these nerves that we have, when we have less branches, when we have the shrinkage process happening, that's why the brain volume is going to go down. Want to be faster. Now, one of the things is going to be affected, it will be our executive function, which is technically so important. Planning, as I said, the frontal lobe. One of the first symptoms that I will say, most of the time I get a call, it's about Thanksgiving time to Christmas time. The kids coming to visit mom and dad, and the first call and say, my mom is always planning Thanksgiving party every year, so nice, like 50 people come to her house. This year, she was so disorganized. That's one of the red flags. That's exactly the planning side. Organizing, that's going to be extremely difficult. Multitasking things is going to starting to become more difficult because of the losing of executive function. And then again, the other things was going to be the processing speed and the type of the long-term memory that we have. And when we talk about long-term memory, we have technically a procedural memory, and we have semantic memory, and we have declarative memory. Declarative memory is the one's going to be affecting more as a long-term memory. Like, for example, episodic memory. When is the anniversary time? It's just a good excuse that if you're getting older, that you can say is part of the aging brain, or a birthday as well. And I'm a geriatrician. I have always this excuse. Nobody's going to question me about it. But the procedural memory is something that you're always going to remember, even if starting to have a dementia. And like, for example, if you just only bike in your life for like 5 years or 10 years of your life, and you never bike again till like 80 years old, if somebody gives you a bicycle, it only takes a minute for you to figure out how to bike. The same thing, for example, is knowing a ski. If you haven't been skiing for 40 years, if you get to the mountain, it just takes 5-10 minutes that your brain's going to find. This is called procedural memory. I still have patients with advanced dementia. They've been amazing pianists, and they're still able to play piano very well. Even they do mistakes sometimes, but they're still playing very well. And they're always trying to teach me piano as well, but I've never learned that. But when it comes to dementia, over 100 diseases can cause dementia. When we talk about Alzheimer is one of the most common one, but we have the mix, which is a vascular and Alzheimer, which is more adopted by European Federation of Neurological Society, which is mixed type, this is true. Everybody has Alzheimer. It's technically a combination of vascular Alzheimer, vascular Lewy body dementia, and frontotemporal. And again, this is, it happens, this 5 is the most common, but the many other diseases, like we have a lot of autoimmune disease. Since we have a COVID, we have a lot of neuroinflammatory related to the COVID, post-COVID, that has started to aggravating the dementia in people as well, which is a very scary part. But let's just say about a story of dementia, because that's so important. The Alzheimer dementia, as you see the picture of Dr. Alzheimer, 100 years ago in the Frankfurt hospital, Dr. Alzheimer had a lady that was 55 years old, and she was admitted in a psych unit, mental health unit in the Frankfurt hospital with the diagnosis of schizophrenia. And the only things Dr. Alzheimer was very questioning about, how come she has a schizophrenia, but she has a severe memory loss? Shouldn't be schizophrenia because they didn't know anything about it. After she passed away, at the age of 56, I believe, he got a permission from hospital and he did the autopsy of the brain. And what is impressive that he found interesting abnormal protein inside the brain of this lady, and that was the first case of Alzheimer. That's what the Alzheimer disease started. That this is not a schizophrenia. This is a neurological disease that happened. But this lady had hallucination, had delusion, exactly like a people with a schizophrenia. That's why they always think about she has a schizophrenia. And they give him medication for a schizophrenia. It's not necessarily making her better, just making her worse. And that was starting the story for Alzheimer. Technically, in Alzheimer, what we see is the amyloid plaque that, again, as you see the nerves, the healthy nerves versus the one with amyloid, the yellow section that actually cutting the nerve system is exactly like electricians come right now and start to cutting the wiring in this building. Half of this place doesn't have a light and half of it has a light. This exactly happened in people with Alzheimer. This is technically the amyloid plaque is starting to getting there. And then later we have other issues as well. Like for example, we have tau protein, which is the tau tangles, is also developing inside the brain. And that's technically causing the more problem over time. But the scary thing is that, again, the diagram, which is from Lancet Neurology, and this is one of the very important things that we need to learn, that technically, as you see the red color and the blue color, which is a tau and amyloid protein, not starting at the age of 60 and 70, it's actually started decades ago. And this is exactly the problem. Like people with this diagnosed with Alzheimer at the age of 74 or 80, the amyloid protein and tau protein started at the age of 40 and 40, 45, probably 35. The disease is starting much decades earlier. This is exactly the area that a lot of neuroscientists, this is the reason we all failing in the treatment of Alzheimer. Because when we get the patient with memory loss, the damage is already done. The only way that in the future we're able to solve the problem is we find the people at the age of 30, 40, 50 that are starting to have the problem, starting to have abnormal protein, and then we treat that at that level. And that's we can prevent Alzheimer in the future. But again, finding this population is extremely difficult. Now, it's growing. It's one of the biggest issues. It will be a leading cause of the death very soon. I mean, it's actually going to replace the cancer as aging growing as well, as you know, and we have a significant aging, again, growing aging population in the world. Right now, it's around 5-something million by Alzheimer's Association has announced. It's probably more because a lot of people, they have disease and they haven't been diagnosed. But we technically going to have a number of the millions of people in the next 20, 30, especially as we're getting more 85 years older all around the world. And that's why the Alzheimer will be, or dementia, will be a #1 issues and the care and the costs. Because when someone has dementia in a family, the entire family will be affected. And that's why this situation will be a #1 crisis, especially in developed countries, Europe and North America, because we have a much more older population in the next decades. And it costs a lot of the money for just taking care of the people. And this is a huge crisis right now all around the world, and the politicians are aware of that as well. No, but let's just go. I just wanted to introduce what is exactly dementia and what is exactly the behavioral disturbances related to dementia. About 97% of anybody has dementia reported to have at least one symptoms during their illness, and mainly depression. I'm not counting even the starting to have some depression. We have suicide as well in people just getting diagnosed. And this is one of the other topics that we talk in all around the world, and especially in some other countries, especially knowing that. But technically, it's a major clinical burden of all the caregiver, nursing home staff, clinician, is exactly increased risk of the caregiver burnout and harm to the patients and the caregiver. It's really a big issue with that. A loss of neurons has been considered the reason of that, exactly what I discussed to you about it. And again, and mainly because of the neuron loss that I talked, a lot of neurotransmitter, especially like cholinergic, which is one of the enzyme between nerves, and serotonin is one of the other one, alternations between non-adrenergic system that happens inside the brain, these are technically affecting the cause of the behavioral disturbances related to the dementia. As I said, the main neurotransmitter, there are like 4 of them as very famous: dopamine, serotonin, cholinergic, and norepinephrine. And think about when, for example, when you see a doctor give antidepressant medication. What does antidepressant medications do? Is our selective serotonin reuptake inhibitor or selective norepinephrine reuptake inhibitor for the hope that we balance this neurotransmitter. When somebody give antipsychotic medication, they are dopamine blocker. Technically, when they did a biopsy or autopsy of the brain of people died of the severe delirium during dementia, they found the level of dopamine is extremely high. That's why we give antipsychotic medication to drop it. Same mechanism that happened in people with schizophrenia is a mental health situation. Exactly happened in schizophrenia people. The dopamine level is extremely high. That's why we give that's why haloperidol is going to come to the picture. That's why other medication, quetiapine, or any medication you take, risperidone, olanzapine, all these famous antipsychotic medications come to the picture. The loss of symptoms that all happen in the picture of people with the dementia, with behavioral disturbance. And this is one of the measures that we use in a clinic, that actually we use this measurement in order to score the patients, and based on that, we can actually treat them. Oh, sorry about that. Oh, here we go. And as you see as like as symptoms, I mean, it's just a lot of the anatomy things, but psychosis, like for example, what happened to the frontal brain or mesotemporal brain, exactly the temporal and frontal lobe that I described to you, red color and remember yellow color. And depression, as we see, a lot of changes happen to mainly on the serotonin system. That's why all the antidepressant medication like citalopram, you hear about them. Sertraline, Zoloft, Cymbalta, they're all coming to the picture. A lot of them, they have apathy. They just completely withdraw. And that's exactly happened in the hippocampal area, frontal lobe. And these are the things that they've done in neuroscience. And agitation, which is technically is a hypofunction of the serotonin and cholinergic system. And dopamine system, as I said, is going to be very hyperfunctional. The dopamine is going to go very high. And this is going to happen in their symptoms as well. No, psychosis, which can be delusion. Majority of delusion is paranoid. They always think about somebody is stealing, somebody coming to the room to harm them, or the caregiver is stealing stuff from them, or hallucination, which mainly visual. And this visual, it can be small people in the room. Usually we call Lilliput hallucination, which is like you probably remember that just the Lilliput is small people, and I think it's Galileo's cartoon that they were small kids, or sometimes they have visual hallucination of the shadows, like somebody is outside of this window, especially in the evening time, they're talking to each other, and that's a visual hallucination that they see. And sometimes they can see animals in the room, or even the people sitting in the room, and they even don't talk. They're just a visual hallucination. They mainly happen on the moderate stage of the disease, and whenever it goes to the severe stage, it's technically disappear. Doesn't mean it disappear. They're not able to articulate this anymore, but they're still living in this hallucination and delusion as well, and can cause agitation, make them very aggressive. And in schizophrenia, this complexity of delusion is just more complex. It's just so nasty, I will say. It's just very sad. They always think about killing, blood is involved, not in the people with dementia. Dementia is mainly seeing the people, but most of the time is a very simple delusion hallucination. And again, most of the hallucination is our visual. Auditory hallucination is more in schizophrenia. The only type of dementia they may have auditory hallucination is Lewy body dementia. They can hear, but they don't hear people talking to them. Mainly music or buzzing sounds is actually they hear, and it's really bothering them a lot, which is very, very painful actually. And when we look at it actually, the incidence and risk factor for hallucination, as you see from the year 1, 2, 3 years, and 4 years, you see the incidence of hallucination delusion has been significantly increased in this population. And it's interestingly, when we look at when we do EEG or electroencephalogram on them, we definitely see that there is an alteration in the cortex, which is a superficial layer, and the serotonin has been significantly low. And when we do the EEG, we see the delta wave, and again, the theta wave, which is C and D, is getting extremely abnormal in these people. And more rapid decline in memory, more chance to get more psychosis symptoms. And that's the people are slowing down on the memory, they do better on the symptoms. But the people goes down very fast, like in 2 months and 3 months, suddenly drop in the memory, is always, when we look at the EEG, we see definitely they have a higher chance of getting more psychosis symptom, which is very, very painful. That's why antipsychotic, as I said, is going to come to the picture as well. All this medication we use, the risk is going to be the Parkinson's symptoms related to this. That's why they need to be very carefully monitored. The risk of cardiovascular, this is the FDA warning about that, and the risk of metabolic syndrome, they start to gaining weight. They're starting to have insulin insensitivity as well, and always the low dose is recommended. We always saying pediatric dose, go up very slow, but treat it. But again, because sometimes it is so important because the guideline technically right now is based on American Geriatric Society and American Geriatric Psychiatric Society is using this medication when there is a harm to himself, herself, and others, or there is a severe caregiver burnout. And that's two terms is so important. We do not recommend antipsychotic in all demented patients unless we have this term. And that's why, again, many of you are in the business of, again, memory care or caregiving. I always suggest that when you're reporting, it is important to understand what is the thresholds of the caregiver. Can they handle or not? Or they're scared of the resident. They're scared of the patients with dementia. This is the time that antipsychotic will come to the picture. As I said, agitation and aggression can be there. Usually we call it as agitation, and that can be physical, can be verbal. And the main cause of any caregiver distress and placement is always that, agitation and aggressions. And everybody, I think, is agree. There is some dynamic factor is involved. Sometimes the cause of that is only pain, is only infection. Maybe just the urinary tract infections going on. Maybe there's a pneumonia. That caused the symptoms getting worse. A lot of environmental factors. I see overstimulation or unwanted care. And unwanted care is very common. Remember, kids, always baby, they hate when we change the diaper. You see how much they're moving their legs and hands in order to not change in the diaper? Because brain feel unsafe and unsecure when somebody comes and take the diaper out, wanted to wipe. This is the normal physiologic reaction to protecting. The person with dementia has the same issue. They do not realize that you're here to help them to change their, for example, underwear or the pull-up. That's why they started to heat. That's why they start to attack, because that's the way the brain trying to protect itself. And it's nothing to do, it's not intentional, it's nothing about personal. That's the way the brain is actually starting to function. A lot of times it's overstimulation. Again, with respectful to all the people in memory care and all this stuff, I don't like when I walk into any memory care and I see a very loud music, especially the rock or heavy metal, they are playing so high, and the people with dementia, they're just getting more sound downing and more agitation. It's not. They cannot tolerate. They cannot tolerate too much stimulation or like parties and with loud caregivers around. That makes them later to have more agitation. They need a very quiet area. I'm not saying under stimulation, we don't do anything, but this is something that it has been done, especially in like Germany. They've done a lot of a study about how much stimulation is going to be good for them. Physical aggression, it's one of the very challenging, 15 to 20% of dementia people, they can be very violent behavior. And again, it's very neurochemical. Again, it's just, we just said, technically, it's a lot of the deficits happen, and more happen in men, and the more severe dementia. It causes caregiver depression significantly, and it's caused significantly great impairment in ADLs and a sleep disorder as well. And depression is also very common, 20 to 60%. I see that's exactly the thing we talk about. Dementia is all about mental health situation. Is first symptoms of Alzheimer's dementia. It's very interesting because a lot of scientists, they think depression in middle age towards 60 can be a sign of a starting Alzheimer's dementia. And that's one of the things that they always think about. Is it a possibility depression is the first manifestation of the dementia, and then later memory loss going to come to the picture? That can be depressed mood, there can be apathy, no interest of doing anything, loss of emotional control. They get easily upset, tearful, or irritable, and worry about future and finances, too much worrisome, not a logic worrisome. And depression may result of the patient's recognition of severity of his and her cognitive impairment, or neurotransmitter dysfunction associated with underlying disease process, which is absolutely true. This is one of the, if the people with the mild cognitive insufficiency starting mild dementia, they're at very high risk of suicide. If they have any tools available, because they're still able to have some frontal lobe and they're understanding about their deficit, this is one of the things we always recommend. Make sure that suicide is not happening, which is happening these days as well in people with dementia. The last thing I want to say, we're still good, Patricia, yes? Sleep disturbances, I wanted to wrap up. And the sleep disturbances is a fragmented sleep. It's technically the reason is brain circadian disorder. They do not understand day and night. Like, for example, if you have someone with dementia here, we have a great, again, place here. So we have a big window here, everybody see the light, but they cannot recognize this as a day or night. They can't. The brain is not, don't have, and I will tell you why. Worse when the disease is getting progress, and there's a lot of neurochemical, environmental condition, and a lot of time is because of us, physician, drug side effect, that actually causing them to have more brain circadian disorder and sleep disturbances. The things about is that I just want to tell you a little bit about physiology of sleep quickly in minutes, that why the people of dementia, they don't sleep well, and why they sleep in the daytime, they started to wandering and moving around at nighttime, and what happened to the brain if the brain doesn't sleep. And that goes to that, and probably, you had probably some of you in my previous career, but this gentleman is a Randy Gardner. He is 1947. He born in 1947. In 70s, he actually had the record of the not sleeping for 264.4 hours, which is 11 days and 24 minutes. Part of the study was just evaluating his brain to see what happened to the brain in 1964, actually what happened to the brain if that. Randy experience is very interesting. It's very fascinating. On the second day, his eyes stopped to focusing. He's stopped to identify the object with touch, not able to see if this is soft or this is the rough. At day 3, he becomes very moody, very, again, and that's all coordinated. Their mood started to change. He started to have hallucination at day 5 and 6, and he started to have short-term memory loss, and he started to become paranoid. They stopped the study, and they recovered him. He's fine. He's still alive. He had an interview with Anderson Cooper a couple years ago in CNN. You go watch it. It's just very interesting. But technically, it's just the story is telling us that why. One part is melatonin. And this is what I wanted to tell you about the melatonin. Melatonin is technically responsible for brain circadian rhythm. Melatonin is the protein inside our body to go to body, from the brain, goes to the body, say, it's the nighttime, go to sleep. Is the melatonin is that night going to tell your bladder, you need to stop to go to the bathroom. We are going to sleep. Is melatonin is going to tell to our large intestine, no bowel movement after 8 p.m. We're going to sleep, okay? And this is the job. Everybody has it. Animal has it, plants has it. This is called circadian brain rhythm. This is the way we live. And when we look at the picture here, I don't want it to go in detail, but technically what happened, light goes to the eyes, from eyes goes to retina, back of the brain, go to suprachiasmatic nucleus, which is processing this light. From there, goes to the place called pineal gland, and pineal gland produce melatonin. Now, when somebody has amyloid protein, all these wirings get cut. That means technically the light goes to the brain, to the retina, from the retina is getting cut. If they have macular degeneration and cataract or glaucoma, the light doesn't go very well to the retina anyway. But from retina, the journey all the way to pineal gland, they're all cut. That's why they do not understand day and night. And this is a circadian brain rhythm. I don't want to go on that, but this is a normal person. As you see here, from like a midnight here, we have, again, the melatonin is going to go up, or body temperature is going to go down, and then in the morning, 6 o'clock in the morning, our melatonin is going to go down. That's why we're starting to feeling to go to the bathroom. That's why always in the building, traffic on the bathroom is 8 o'clock in the morning to like 9. And then the highest alertness is 10. Thanks to Patricia Maxwell, put my lecture at like 10 o'clock, that everybody's alert enough to understand what's going on. Afternoon will be more exercising time. The best time for exercising is in the afternoon because we have a maximum capacity of cardiovascular, and this is exactly the circadian brain rhythm. And around the 1800, I mean, like at 6 p.m., 7 p.m., I think in California now, the sunset is around 8. The melatonin is going to get to the peak, and this is the time that our body is started to going ready to sleep, and this is the way it is. The melatonin is going to go high around like 20. This is, think about we live in California. It's not Scandinavian. It's not Alaska. And this is California. We're paying tax for it. And then that's why the melatonin is going to be in the highest there and then go down in the middle of the night. And this is the way it works. No, but it's so important. The people with dementia, all these pathways are broken. And also, some of the neurotransmitter, like dopamine, is also broken. The other things is important is understanding about adenosine. Adenosine is a protein that is built up during the day in our brain, and its technique is a product of the muscle use. Like, for example, even you're sitting right now using your muscles. You're crossing your legs. You're taking coffee in your hands. You're still using your muscle mass. But if you do exercise, you produce more adenosine. Adenosine is the cause of the sleep pressure. Technically, whenever the adenosine is going to go very high, then this is the time you see the eyes goes like this guy. That means there's too much adenosine in the brain. And this is exactly the reason. Now, what can block the adenosine? Coffee. I see on a lot of people on the table, they have caffeine. Caffeine is technically blocking the adenosine, stopping the adenosine. That's why it wakes you up. But there is a limitation of how much caffeine can block the adenosine. But this is why the exercises help to sleep better. Because when you use your muscles, you build more adenosine. That's why later of the night, you're able to fall asleep better. Many people with dementia, they're very sedentary. They don't do any activities. That's why later of the night, they can't fall asleep because there's not much adenosine in their body anyway. And what happened at night, I just want to quickly pass on that. There's something we call glymphatic system, which is technically from the spinal fluid, goes to the brain, and it started to clean up all the adenosine. This is why. If you have your janitorial system at night works very well, and take all the adenosine out, next morning for aging conference today, you're fresh, you're ready for the day, and you're happy because you got rid of adenosine. But this is a very important thing that we need to know. Why the people, and I don't want to go on detail on that, but look at the people, they have interrupted irregular sleep pattern. This is people with dementia. Because in normal sleep, you sleep, for example, from 10 p.m. to like 6 a.m. if you're lucky, and you get this sleep. Delayed sleep disorder are the one that actually they sleep at like 3 a.m. to 12 p.m. Who are these people? Teenagers, young people. This is normal for them. Don't blame them. This is normal for them. And the advanced sleep is the people are getting older, especially after 70 years old. We sleep earlier. We wake up 3 a.m., open wide, and say, oh, I can't fall asleep anymore. This is also normal because the way the melatonin is shifting. But in between, irregular sleep pattern is exactly dementia people. They are sleeping for 2 hours, then they wake up for 2 to 3 hours. And they sleep another 2 hours, and they wake up again for 2 to 3 hours. This is normal. This is why giving a sleeping medication to any people with dementia, it's the wrong things in medicine to do. Because when do you want it to calm the brain? This is the way the brain is acting. This is why a lot of places in the world, they're adjusting their memory care staff to understanding about the irregular sleep cycle. not expecting the people with the dementia fall asleep at 10 p.m., wake up at 6 a.m., fresh, and said, hey, good morning, I'm ready for the day. That's not possible. That's never going to be possible. The key point, I'm done. Sorry for all headache. The psychological symptoms and behavioral abnormalities are common and prominent characteristic of dementia, and this is sad. This is sad, and the reason it's sad. Many people with dementia, they go to emergency room, and they ask to admit them in the psych unit. But they don't belong to psych unit. None of the psychiatrists accepting them. I said, no, this is dementia. We don't admit dementia people in the psych unit. But they have the same. They're agitated, they're aggressive, and they're hitting the people, caregiver. Even they call 5150 in a skilled nursing home for people with dementia. Harm to others. But they don't hold it to 5150 because the person has a dementia. It is the sadness about this disease. It causes mental health. 30 to 90%, imagine. Someone with no past medical history. This is the heartbreaking part. The kids come to me and say, my mom was the sweetest person in the world. Now she's mean. She's saying the stuff that I cannot tolerate. My grandchildren, my children, which is the grandchildren of the patient, they don't want to see the grandparents anymore. That's exactly the sadness of this disease. Because it's not somebody just been having this mental health situation for all life. Suddenly, everything's just changed. And again, the approach for the patient is really different from people with mental health. And we need a lot of expertise globally. We're not good in the United States, I have to say. We're really not good. We don't have enough experts in treating the people with dementia. We have one of the highest number of dementia patients, and it's just growing so fast, but we don't. We still need a lot of expertise. I'm not blaming the physician side. We're horrible. We are horrible of really understanding dementia, how to treat dementia, how to treat the behavioral disturbance-related dementia. No knowledge. The medical students in the entire 4-year medical school, they only get 1 hour to 2 hours of training to knowing anything about aging. That's all. And during the residency, if they go to primary care, they technically get in all 3 years only 1 week rotation. They have no knowledge. Most of primary care doctors, they don't know what's going on. And even geriatrician, I'm a geriatrician. I just learned through the field. And this is exactly because every case we just see the numbers increasing. And this is exactly the point. But anyway, I'm just going to stop here. That's my email. If you have any question, feel free to email me as well. And again, thank you so much for inviting me. Thank you so much, Key, for a nice introduction and kind. And I believe this is my first presentation that I'm on time. Is that correct? Wonderful. Thank you so much. Then they're going to invite me again. Thank you.
On behalf of Patricia and the Rotary Club and all the folks involved in this, we just wanted to give you a small
Thank you
gift of
so much.
appreciation.
I appreciate it. Yeah, thank you so much. You're welcome. Thank you.